Hi, I'm Andy Wible and welcome to Timely Topics. Today we're going to be talking about palliative care and hospice, and with us today is Mary Anne Gorman, and she's Executive Director at Harbor Hospice. Thanks for being with us, Mary Anne.
Oh, I'm really happy to be here, Andy.
Oh, good. Well, I know you do lots of things in the community, but your main job is Executive Director of Harbor Hospice. Tell us a little bit what an Executive Director does at Harbor Hospice.
Well, a lot of things. In fact, I tell people that probably no one day is ever the same, which is the challenging and also the interesting and fun part of this kind of work. I would say one of the main responsibilities I have, of course, is the day-to-day operation of the organization.
Okay.
And over the years, we've grown quite a bit. We have almost 100 employees.
Wow.
And that many volunteers.
And how long has Harbor Hospice been around?
We're celebrating our 30th anniversary.
Wow. Okay.
And a big responsibility to carry the message out into the community in terms of exactly what it is we do, the services that we have to offer to terminally ill patients as well as their families, and make sure that we're really meeting the needs of the community and meeting our mission. Mm-hmm. Mission is so important. We are a nonprofit organization, and as a nonprofit, we have a unique and special responsibility to know and stay in touch with what the needs for end-of-life care and resources that people in our communities have.
Mm-hmm. So maybe can you give you said you want to get the message out of the mission of hospice and what you do. Can you summarize that for us?
Sure. I think that at the core of what we do is to provide comfort care to individuals that that are living with a life-limiting illness. Mm-hmm. And of course that includes not only providing support to help them stay at home, or if they are in an independent living or an assisted living facility, even a nursing home, we can go in and our whole team of hospice professionals provide an array of services, and that includes any medication that they might need to manage symptoms that they might have, as well as social work services, the services of our chaplain, because we address spiritual concerns. So it's really a holistic approach to help support that individual and help them draw on what coping skills they already have, and then help the family members also give that individual patient support. So it's a very comprehensive program, and I think one that is enriched by the fact that it's a team approach.
Right.
It's really not a medical model per se, although it's very solid and good medical care that we are giving. But it's broader than that, and it also taps into what the inner resources that individuals have to deal with their particular situation, and to really focus on what's important to them.
Right.
I like to say that in addition to asking the question, what's the matter, we also, even more importantly, will ask what matters to you, and that's really where we want to start. You know, for individuals that do have a limited life expectancy, I think it's even more important to say, how do you want to spend this time?
Right.
You know, and we're going to do all that we can as an organization to support you to meet whatever goals you have.
Yeah, I think I remember some films that were out around the year 2000, because they were dealing with what's if the world comes to an end in 2000, you know. And I saw a couple of films that were just excellent about what would you do if you only had a short period. They had 30 days to live, knowing that the earth was going to come to an end. And people had various ways of spending those last 30 days. And in a way, that's kind of what you're dealing with people saying, hey, how are you going to spend those last 6 months or 2 months or 1 month?
Well, I think it is. And of course, many times patients will come to us after they have struggled with an advanced chronic disease for a long period of time. And so for them, they may have had the experience of being at a very low point where it was anticipated that they might pass away, and then they rebound. Yeah. And so it really is, it's not always easy to tell, you know, how much time people have. And, you know, patients will ask their physicians, and families will ask our team, and we can't always tell. Yeah. You know, it's not something that is really easy to pin down. I do think through our experience, however, there are ways that our medical director and the patient's physician, looking at a whole series of what the situation is and where the patient is in the whole trajectory of their disease, if you will, they can make an educated guess. But that's really all it is an educated guess. And
but so people want answers often.
They do.
And but maybe the honest thing is to say, I'm not really sure, but here's what we've experienced in the past.
Right. And what we say to physicians sometimes is, would you be surprised if this patient passed away within 6 months? And then they're able to say, well, no, not really, because of this, this, and this. And so that's kind of how we get at, do they meet the criteria for hospice for us to bill Medicare? Because Medicare asks us to make a prediction or projection that the prognosis is 6 months or less. And there are times when people will outlive that. In fact, 10% of patients that come into hospice actually graduate from hospice. We laugh about it, but they
10%, you said?
Yeah, wow. They improve. They do better if their medications are managed. They have psychosocial support. They feel less stress. They're getting help with personal care in the form of our home health aides, that, you know, helping with baths and personal care. Volunteers will come and spend time with patients. There's more interaction.
So after they would transition out of hospice, is there care still available for them? Or?
Well, there are a variety of resources, and we have a responsibility to try to connect them, certainly, with other services. We're fortunate that we have a great network of services for seniors, senior services. They may qualify for home health aid services. Then there are other comfort keepers and other types of aids, Meals on Wheels, and those types of services that really might help them.
And if the anticipation is 6 months or less, that's one of the criteria for being in hospice?
And the other would be mainly that there is a diagnosis of an illness, a terminal illness, and so, and that's what hospice has to document too. You know, there really are guidelines, because Medicare has said we want hospices to be able to deliver this care, but it has to be within a framework, and the framework is that prognosis of 6 months with a diagnosis of a terminal illness. When hospice first started, most patients, the majority of patients, of course, were patients with cancer. But as hospice has evolved and grown in the U.S., there's become more of an awareness that we can help patients with or at the end stage of a chronic disease, such as heart failure or a kidney disease, or even end-stage Alzheimer's disease and other neurological illnesses.
Right. My grandmother had Alzheimer's disease, and I mean, she got to the point where she could not swallow well anymore, and I believe hospice helped just for a short time, because we said we don't want a feeding tube or anything like that to keep her alive. Would that be a time when hospice
Again, they're criteria,
Yeah.
and so our team, our intake specialists, usually our intake nurse and a social worker, along with our medical director, will consult with the treating physician, and we have guidelines that we use because it is not meant for a long term, and that the good news is people are living longer. But it's also true that they're living longer at times with an advanced chronic disease,
Right.
and they do have medical needs, but they may not qualify or meet the criteria for hospice.
Yeah. You said people are living longer, and that's definitely true. Are they living better, I guess, is what sometimes I think about. There's a philosopher I know wrote that used to be that people died too soon, too early, and now he says people die too late. They linger around. So I think hospice has some role in making sure the last part of your life isn't one that's so awful, I guess.
Well, and that becomes very personal because I think you hear a lot of discussion, particularly these days, about patient-centered care. And I think, again, in getting back to that question of what matters to you, what are your goals? If you build the care around what the patient, what a life well lived, means to that patient,
Right.
and that can be very challenging. I mean, let's not, sugarcoat it.
Sure,
It's difficult. People have had losses, for example. Many people in our communities have been very active. They've been hardworking people. We have great resources here for outdoor living, fishing, hunting, hiking, all kinds of things.
So to not be able to do those things.
To not be able to do those things
Yeah.
is a loss, and adjusting to those kinds of limitations, is not easy. And so I think one of the things that we do in hospice is to try to help individuals as best they can and as best we can help come to terms with the reality of that situation and find other ways to find meaning and to feel fulfilled. But it is a very personal thing for folks.
Yeah. Some want to maybe be with their family, others maybe desire some more mobility with pain, or wouldn't it? I suspect it just differs.
It does differ,
in many ways.
And yes, and I think being with family, surrounded, most people, if you ask, and all the surveys will show that where would you want to be if you knew you had a limited amount of time, and people will say, well, I want to be at home, I want to be, with my family, but sadly, it's about 75%, but it's upside down, because what happens in our country, even today, even though hospice has spread and grown, is most people are going to die in the hospital or in a nursing home. I think it's about something like 50% will die in a hospital and 25% will die in a nursing home. So there you go. What people are hoping for isn't always, how it turns out.
Why is it that we get people into the hospital or the nursing home to die rather than where they'd like to be?
I think there are a lot of reasons. One, we already talked about, which is it is hard to predict. Is now the time when we really should the focus should be on comfort care and comfort measures, as opposed to trying to rescue.
Right.
So it's hard to discern. I think sometimes we get a little carried away with the fact that there are interventions that we can try, even if they may be long shots, if you will. Sometimes people feel, well, if there is an option, then I should do it, even if in their heart of hearts it may not be really what they want to do, And so we have a hard time accepting, the reality. And people ask me quite a bit usually. Well, if I have hospice, doesn't that mean I'm giving up hope?
I was going to say, yeah.
Yeah, and I think, you know, what we've learned to query back is, well, what does hope mean for you? Can you hope for things that might be more realistic, given you do have the burden of this disease?
Right.
You know, what could we help you do that would, again, add some joy and meaning to your life that is within your grasp? And so, again, it is very individual, and people come to terms in all different ways with what that situation is.
I wonder if it's maybe doing everything you can do. I know people feel like that's an obligation that they have in life, and that they can't give up on life. But that this is something you can do. I mean,
it is.
And it's something that can help you, can help your family often.
Well, and I try to point that out whenever I have the opportunity, like when I, you know, do programs like this, to remind people, and even providers or clinicians, practitioners in healthcare, to stop and think before the message to a patient is, there's nothing more we can do. That's not a helpful message.
Right.
That is not a helpful message. Instead, try, there is nothing that we know of at this point that is going to stop the progression of this disease. However, there are many things that we can do to help you be comfortable, to address fears that you might have, and worries that you'll be a burden. Because people have a lot of fears. They fear they're going to be in pain. They fear they're going to be a burden.
Right.
They fear that the cost of their end-of-life care is going to break the bank. So there are, you know, those kinds of concerns that hospice can really help address. And so you can turn that around and say, yes, you know, there is not a curative option available, it would seem, any longer. But let's focus on all of the many things that we can do.
Right. I had a friend who, from graduate school, and I don't really see him too much anymore, but his mother's been dying, and just died last week. And he was posting many things on Facebook about how she was doing and what he was thinking. I think he's a writer, so I think it was kind of cathartic for him to get that out there. And I remember he posted this quote up. It's from Jean Kootner. I don't know if you know her, but it says, do not necessarily fear dying. I'm sorry, people do not necessarily fear dying. They fear pain, they fear losing control, they fear losing dignity. When our healthcare system can treat all of those symptoms and concerns, palliative care will have realized its potential. Do you think that sounds right?
It does to me, but you know, I've had the good fortune to have 28 years of experience, you know, working with a whole staff and group of volunteers that are doing this work, and it's our patients and our families that have taught us, really. You know, I mean, we're trained social workers and nurses and physicians, and so we have that professional training, but you know, when we do our best work, I think, is when we're listening to what is on the minds and hearts of patients and their loved ones, you know, and take our cues from them, and know that we can help, because sometimes the things that people worry about and have the most fears about, we can truly help them understand that the likelihood of whatever that is, of happening, is very low. Okay. You know? And so I think it's good, you know, to provide reassurances. I can remember my own dad, who lived in another state, and we had hospice for him, and I spent as much time there as I could, and he had lung cancer, And one of his fears was that he wasn't going to be able to breathe. I mean, he was worried about that.
Sure.
And it would be, you know, it's certainly understandable. You know, I think anybody in that situation would have that concern. And so we had a pretty candid conversation around what is in the hospice toolkit that was going to be able to help him if he got into that, in that situation. And that was a lot of reassurance for him, you know. And, you know, and I wasn't saying anything to him that I didn't know from my own experience and truly believe. So.
And do you think he was helped in ways that made his life meaningful?
It gave him a lot of peace and a lot of comfort. And he died a very peaceful death. And so I have seen the benefits in my own family firsthand. Yeah,
and you know, we're all going to die, and that's we only are going to do it once. So it's not something we're always prepared for, but it's something we hope to do well, I hope.
Well, we don't have a blueprint for it, that's for sure. In fact, you know, one commentator at one point, you know, made the comment that we sort of go around acting like death is an option. You know, it's going to happen to somebody else and not us, and I don't want to talk about it. But, you know, one of the things that we consider to be part of our mission is to help adults have conversations before the crisis, so they can really share with their loved ones, with their physician, their own doctor, what their own values and preferences are for their care. And so that's a whole area that we think needs more attention and really ought to be discussed much more. We have, in the state of Michigan, we have tools that folks can use either with their own attorney or even get off the internet, you know, the information you need to put together an advance directive. And
it's a very small percentage of people that have an advance directive,
if
I'm not mistaken.
You know, and again, that's one of the contrary things about this. People will be if you ask people what do they want, they're firm. I want this, I don't want this, blah, blah, blah. But then
do you have the advance directive? Oh no.
No, and then they don't want to talk about it all that much. So we have to sort of challenge people to take advantage of the tools that are there. And the second part of this, besides saying, you know, this is what I would want, is to communicate it to your durable power of attorney for health care, or it's sometimes called a health advocate or a healthcare proxy. And that's the person that you have identified as who you want to speak for you, only in those situations where you're not able to speak for yourself. And so there's a way to do that, and more people should take advantage of that opportunity and document who you want to be your advocate if you should be in a situation where you just can't communicate what you want.
One prominent example was the Terri Schiavo case, where there was no document and there's disagreement.
And people will say, which is interesting, the three landmark cases that have gone, you know, to the Supreme Court over the past 20 or 25 years, maybe longer than that, have all been young people. So it's not that this can only happen to
I'll wait till I'm on hospice. No.
Right, and so our position is that having an advance directive and having that durable power of attorney as part of your estate plan is it's good medical care. It's just good common sense, and it should be the standard of care.
Sure.
You know, it's not something, and so to anybody that is having the experience of in their doctor's office and the physician says, well, do you you get asked that, don't think that that means, oh, something's wrong with me.
Yeah,
no.
eyes get big and uh-oh.
Yeah, no, it's really should be, the standard of care. And then you update it,
Sure.
as your circumstances, because if you're a healthy adult, you may have one idea about what you want, but then if you get into a situation where you're having different challenges, then you may want to address that and update your plan.
Right, right. You had mentioned one concern sometimes I think people have with hospice is that they're giving up. Another one I hear is sometimes I think that people say hospice might shorten my life and I shouldn't ever shorten my life.
Right.
Is that a proper interpretation of what hospice does?
I think it's a concern that people have, and certainly with healthcare reform, we heard people's concerns, and I think that our philosophy has always been hospice neither hastens nor prolongs a dying process. And I think what we see is people coming into hospice care too late, from our point of view. Very short lengths of stay, we're really not able to address and provide all those supports that I mentioned earlier, and that's too bad.
Yeah, so they might have a really unfortunate existence and then finally hospice is called and you can help what you can, but there's just not much left.
Right.
Huh.
I think it's always better for people if they begin to think that hospice might be helped. There's no cost to having us do an evaluation and get the information from the treating physician. And if we think it's not the right time, if they don't meet the criteria, we're not about getting people into our program that we don't think are appropriate.
I see. Okay. And do you work with all hospitals in the area that you serve?
We do. Well, now we have basically one health system plus North Ottawa. We also serve Mason County, Oceana County, and part of Newaygo, and then Northern Ottawa. So.
Well, there are more than one hospices, right?
There are, and that's
How do you know who to call? I mean, I'm sure you'd say, well, there's one to call, but...
Well, I think you have to know, you have to ask some basic questions about how they're staffed. Do they have volunteers?
But it's really up to the individual. It's not the
Patients
medical...
have choices.
Okay.
Right.
It's not their doctor or their hospital.
Should be the patient's choice.
Okay, good, good.
Yeah.
And are you, one last question, are you going, do you foresee any big changes in hospice, or do you think just expanding your role as you currently have it?
One of the goals we have is to see if we can help people with palliative care, and this would be upstream from hospice, so to speak. People that don't have that terminal diagnosis that we talked about, but because they are living longer, they may have symptoms that we could help with, whether it's pain control or other symptoms that our palliative care trained physicians can be helpful with.
So for palliative care, interesting. Yeah. Well, I think that's a lot of good work to be done there. Make lives better for people. Yeah.
That's our hope.
Yeah.
Right.
Well, thank you for coming on, Mary Anne.
Time was short.
Yeah, it goes quickly. Yeah, covered a lot of stuff. But I think a thoughtful discussion. So thanks for all you do. And thank you for watching Timely Topics. We've been talking with Mary Anne Gorman, the Executive Director at Harbor Hospice. And until next time, have a wonderful day.